This is Herb Kressel, and welcome to the September Radiology Podcast. This month we have discussions with authors of three provocative papers. First, I'll be speaking with Dr. Sadhna Nandwana of Emory University, who with her colleagues wrote a very interesting study on the use of gadobenate dimeglumine in patients with impaired renal function, looking at the subsequent incidence or potential incidence of nephrogenic systemic fibrosis. Then my colleague Dr. Deborah Levine will be speaking with Sanjit Ghai, who with colleagues from the University of Toronto published a study looking at the quality improvement effects of thyroid biopsy specialists in terms of wait time reduction and biopsy accuracy rates. And finally, my colleague Dr. David Kalmes will be speaking with Dr. Chi-Jen Chen of Taipei Medical University in Taipei, Taiwan, who wrote a very stimulating article exploring the sex differences in working memory after mild traumatic brain injury. We hope you enjoy this month's podcast. And a special note, this month we have available transcripts of the podcast discussions. We've learned that many of our listeners and viewers may not be that familiar with English as a language, and we feel that the transcripts will be helpful in furthering their understanding of medical English. We hope you enjoy the podcast, and we hope you enjoy the transcripts. Please contact us with any suggestions for further improvement. Hi, this is Herb Kressel, and welcome to this month's edition of the Radiology Podcast. Today, I'm joined by Dr. Sadhna Nandwana, Assistant Professor of Radiology at Emory University, who with her colleagues authored a really fascinating paper on the use of gadobenate dimeglumine in patients with impaired renal function. And as there's a lot of interest in NSF and the gadolinium-based contrasts, I think this is a very, very timely article. And so welcome, Dr. Nandwana.
Thank you for having me.
And in full disclosure, Dr. Nandwana trained with us in Boston, and I want to welcome her to the podcast. We're very proud of you.
Thank you so much for having me again.
Sure. Okay. So gadobenate is in a class of the gadolinium-based contrast agents that have been associated with few or any NSF cases. And what's the explanation for this? Why do people feel that these...
So that's a great question. Basically, it comes down to two properties. One, it's felt to have it has a higher relaxivity profile so that it's you can use smaller doses than, say, other agents. And then the other factor is that gadobenate dimeglumine actually has partial hepatic clearance. And so that's felt that in patients with renal failure, since it's getting partially cleared by the liver, that confers an extra safer profile to it.
Okay. And then I would imagine it sort of took some gumption to decide to use a gadolinium-based agent in patients. I gather these were part of a transplant workup. So could you tell us the thinking of why you decided to do that as opposed to some of the alternatives, non-contrast enhanced MRI or other modalities?
Sure. We have a very strong MR program here at Emory. And it's part of our practice pattern to image in conjunction with the nephrologist all of our pre-transplant recipient patients with MRI and MRA with contrast. We'd actually started with gadodiamide prior to 2007 and had seen some cases of NSF, and that's why we switched over to gadobenate dimeglumine. And we found that these patients that are getting screened prior to transplant with contrast were able to pick up unknown malignancies, some vascular abnormalities that would otherwise have been missed. And so we have a very strong relationship with our nephrologists and our transplant surgeons to go ahead and use the contrast and image these patients.
Now, some people sort of looking at the sort of same issues would try to use some of the non-contrast MRA techniques, or people are also advocating diffusion-weighted imaging to look for these neoplasms. How did you kind of weigh the two different approaches?
So we basically set out to say, we want a diagnostic study. We don't want to have to hedge and say, well, there may be a neoplasm there, and especially given that, we have a lot of dialysis patients that are at risk for RCCs. We want to know about this preoperatively. And so we said, well, if we have a strong relationship with our nephrologists and our transplant surgeons and we're giving them contrast, we can screen them effectively for NSF. We knew that we were able to detect it prior to with gadodiamide as we were able to identify those patients. We felt pretty confident that we could control, the narrative basically.
And I think you're also, are you dialyzing them soon after the contrast administration?
Correct. So if the patient's already on dialysis, they have to get dialyzed within 36 hours. However, we do recommend within 24 hours. And so this is practice, as soon as the patient checks in, we confirm with the patient, with their nephrologist that they are on the dialysis schedule prior to receiving the transplant, prior to receiving the contrast.
What did you actually do in your study? What was the study design?
So our study design was a retrospective review of patients that had renal failure and were presenting for an MRI or an MRA for the evaluation of a pre-transplant workup. And we were looking at this patient population specifically because they had known renal disease, and we wanted to see the effects of having received the gadobenate dimeglumine. Once we identified those patients as patients who had received a study during 2010, we conducted a thorough chart review, and we looked at all the clinical notes that were available in the electronic medical record for both the presence of NSF or NSF-like symptoms in their skin exams. And we recorded the latest follow-up for two types. Basically, one type where it included a dedicated skin evaluation by a clinician, and then the latest communication, which may or may not have included a skin evaluation.
And what was the overall length of follow-up?
So for the length of follow-up for patients that had a dedicated skin exam by a clinician was about 2.35 years. That's the average. And for the follow-up with any communication was about 3.1 years.
And you also, in the patients examined during the target year, which was 2010, you looked at all gadolinium-based contrast administrations from 2007 through 2014. What was the logic for looking at that?
Right. So what we wanted to know was, these patients we know they received gadobenate dimeglumine on that index scan. And what we wanted to know was, were there other times that they had received a gadolinium-based contrast agent? And if so, could that have contributed to whether or not they developed NSF?
So if they had developed NSF, you'd be able to see if there's a confounding factor as opposed to just pure gadobenate.
Correct.
Okay.
And so, unfortunately, we didn't have anything prior to 2007. That's when we went electronic. So we were able to look from 2007 onwards. The other thing that it allowed us to do was to see what the effect of multiple doses had on patients. Out of the 400 patients, we did find that about 66 had received additional contrast for other unrelated studies.
Okay. And what did you find with your review?
So we found a 0% incidence of NSF in our patient population of renal failure. And interestingly, we had patients that were on dialysis, whether it would be peritoneal dialysis or hemodialysis, as well as patients that were not on dialysis but had a very low GFR. And there was no difference in the incidence of NSF in those patient populations.
Right. Well, that's sort of impressive. Now you studied 400 patients, but do you think that sample size is large enough for this to be a meaningful result?
So it's an interesting question. The incidence of NSF with gadobenate dimeglumine is really, it's unknown. I mean, we have no unconfounded cases reported. So we're unable to really do a power calculation to see what should the sample size be. That being said, agents that have been associated with NSF, so agents such as gadodiamide, in a similar patient population, which is renal disease patients, we do know the rates of NSF in those patient populations, and those range anywhere from 1 to about 18%, depending on the type of study that was performed.
As an incidence.
As an incidence, correct. And so, what we assume is that if we kind of extrapolate that data out to gadobenate dimeglumine, which is they should have a similar incidence of NSF in the renal failure population, our study of 400 patients would be powered enough to detect at least a 1% incidence.
Okay, that's impressive. So as I'm sure you know, there have been several recent reports about increased signal intensity in the dentate nucleus and other nuclei in the brains in patients who've received gadolinium-based contrast agents. And it's been shown that this was due to gadolinium deposition in the brain. Have you had the opportunity to go back and look at the head scans of your patients in the study, if they were obtained, to see if there was any increased signal?
Yeah, not yet, and it's a great idea, and I think we definitely will be doing that in the future.
Okay, well, good. Now, here we are. I guess the study year was 2010. So what's your current policy regarding MRI in this patient group? Did you just sort of continue what you were doing? Is there any further modifications?
Yes, so we are continuing what we're doing, and basically what the study showed for us was support and that we could continue to do what we're doing. Right. And so we're going ahead and proceeding with our policy of imaging all of these patients with gadobenate dimeglumine.
Now, in the article, you suggest that you allow 3 lifetime doses of 0.15 millimoles per kilogram of gadobenate. And then how was that actually arrived at, and how do you manage it?
Right. So it's a good question. It's basically a trial and error in what we feel comfortable with. So, we can say that we've imaged literally thousands of patients that have renal disease with gadobenate dimeglumine with no problem. And now we have data that's been published to show that. We're not as cavalier to say we're just going to do it forever and ever. So what we came up with a number of 3. It's been our policy for years. And so what that really means is that when a patient comes in with renal failure, and for the first 3 scans, the technologist does not even call us up for approval. Okay. After the 3rd scan, when they're coming in for the 4th or 5th or 6th exam, the technologist will call us up and say, hey doc, this patient's coming back for X number of scans. Do you still want to give contrast? Okay. And at that point, we don't have a policy. It's kind of whatever the person feels comfortable doing. So someone
makes a judgment at the time, but exactly. It's kind of like a threshold to revisit and reconsider.
Right, which is basically what the ACR recommends for any group 2 agent. What we do is we just push that threshold up higher to after the 3rd scan.
Very good. Well, Dr. Nandwana, I really enjoyed chatting with you. I thought your article will be of interest to lots of folks who are trying to figure out how to examine patients with severe renal disease. And thanks for taking the time to join the podcast.
Great. Thank you for having me again.
All right. Bye-bye.
Bye-bye.
Hi, I'm Debbie Levine. I'm the Senior Deputy Editor for Radiology, and I'm here today talking with Dr. Sangeet Ghai, who is an Associate Professor of Medical Imaging at the University of Toronto. And he and his group in Toronto devised a study to look at mid-care providers to ease the radiologist workload and provide a better patient experience for thyroid biopsies. We live in a healthcare environment where we are continuously being asked to do more with less time. And in addition, thyroid biopsy rates have just exploded. So I found this paper to be very interesting and very timely as well. So welcome, Dr. Ghai.
Hi, thank you for having me. It's a pleasure to be here.
So I kind of mentioned what I thought some of the drivers were for doing this study, and I'm wondering if you can mention as well What was the impetus for having these mid-care providers? Was it financial, efficiency, turf issues? What drove you to do this?
So really to go back, and this is, I think we're talking about 2009 and 2010 when we started thinking of this program. The primary reason was we were receiving a lot of complaints from our clinical colleagues. The wait times were going up. How we functioned was, we have a dedicated biopsy center at the hospital, and we used to do deep abdominal biopsies in the morning and do the superficial biopsies in the afternoon so that we didn't have any recovery time, and then they could go home immediately after that. And there were only so many we could do. Plus, if I can say, there really wasn't a consistency in the program. So, you would have a first-year resident someday who would be doing the biopsy. The second day it might be a fellow. Some are more experienced than others. And there was kind of a bit of a disinterest in a program, I would say. How we were doing it, we're really not following up, getting enough follow-up as to, when you do a biopsy, was it an adequate specimen or not? And then you have inadequate specimens and the patient comes back for a repeat biopsy. That adds to the wait time. So we were following up the wait times of about 3 months for a thyroid biopsy or even longer. So a lot of complaints coming from our physicians, head and neck surgeons, endocrinologists, and that's when we started thinking as to what we can do to provide better service to our physicians and more so for our patients, actually.
So can you tell us a bit about what exactly you did in this study and what you found?
Absolutely, I would love to. So when this first came up, this was something, as the director of the biopsy center in the hospital, the chief actually and I had a chat, and he really wanted to set this program out. The first thing we did was bring this up in our divisional meeting to all the radiologists in the group to see if this is something they would be interested in. And surprisingly, there was an overwhelming support that yes, we should do that. This would be better for us. It would in fact free us also to do the other, radiology reading scans and stuff and free up their time as well. So the first step was getting approval from the radiologists, but we knew that there are going to be many, many obstacles in the path. Then I spoke with our the CMPA in Canada, which is the Canadian Medical Protective Association, if there would be liability coverage for the physicians. And they, if I can actually quote here from the paper, they said, it is a delegation of a medical act could be considered part of the professional work of medicine, but you would need to get approval from your regulatory body of the province, which was in our case the CPS, so the College of Physicians and Surgeons of Ontario, and also get consent from the employer of the sonographers or the MRTs that you would train, which in this case would be the hospital. So we knew that we had to go back. CMPA would be fine if we could go back to CPSO and the hospital MAC. So the first step was to go back to the college. And they again have a very clearly defined a policy for delegation of control acts on the website, which again said that you could do it provided you include proper identification, evaluation of the individuals, how you train them. That should be there. There should be an established process for the delegation. And then there should be maintenance of competence and train them for informed consent as well. So I thought we could, when we read the act, the policy online, we thought, yes, we could easily go through that. It's going to take a while, but there's no reason why this is not possible. And the third step was, again, for the medical liability of the sonographers, we had to go back to the hospital. So when we looked at all this, we knew that, we really needed the approval of the hospital MSc for them to approve for this entire process. So we put forward a plan of how we would train the sonographers in a stepwise manner, and we put this to the hospital MAC. It did come up in the meeting. The first time, actually, it did not pass through, and that was because some of the pathology colleagues had concerns about, our adequacy rates were not very good. And is this actually going to even further make it worse? Or are we going to open the floodgates and start doing thyroid biopsies on each and every patient just because we're opening, having new sonographers perform the biopsy? So it didn't pass through the first time. We took it again. We did have discussions with the pathology division, how to work closely with them for on-site cytopathology and when to ask for on-site cytopathology. And I think the second time it just whizzed through. It wasn't a problem. The hospital approved it. So when the hospital approved it, we were, I think, on board. The whole process could get now started to train the sonographers.
So you trained your sonographers, and tell us about your study and what you found in your study.
Sure. So initially, when we initially thought, should we train MRTs, radiation technologists, or sonographers? But the fact that, sonographers already have some hand-eye coordination, and the fact that they're licensed to practice sonography, to do ultrasounds in the province, we thought it would be better to train them. It would be easier, actually. It would be a one-step just to train them for the biopsy. So we had a one-day training program which included didactic talks from the morning till the evening, actually. We showed there were some video demonstrations as well. The second step in the training was phantom training. So they did there was a one day full of phantom training or half a day of phantom training. The third step was having them come to the biopsy center, observe us, how we do the procedures. And the fourth step was a one-to-one kind of a training for them. So they would all come in to the biopsy center just for the afternoons when we did the superficial biopsies over a period of about 3 weeks, when they did about 25 to 30. And then they would be signed off by the radiologist who would have supervised them. So we did that. So it took us, I think, it took us again a few months to train 4 sonographers. And then we started them to do the thyroid biopsies independently, but under supervision in a room which was made available right next to the deep abdominal biopsy room. So we would have, there's a control room. On the left-hand side, we have the deep abdominal biopsy. On the right-hand side, we have the thyroid ultrasound room. And so initially we started slowly. We would only book about 3 patients in the morning. They would do a full ultrasound. They would document the ultrasound. They would call us to the room to show us the images and think what they thought, which nodule should be sampled and which should not be. And once we agreed on which nodule should be sampled, they would go ahead and do the biopsies. And only if they had an issue, they would call us. We were always there available in the very next room. If you're doing an abdominal biopsy on the ultrasound gardens, it takes about 10-15 minutes. So if worst to worst, you just wait for 10 minutes, and then we would come across and help them if ever help was needed. So it's been running well. It's been about 3 years, more than that now. So what was published in the paper was our adequacy rates just for the first year when they started. And I think it went from 74 to 78%. In the very first year, but I do have some data now for 2014, which actually says that the adequacy rates have gone up to about 90%. So I think this has been very successful program for us. Our clinicians, we keep meeting them, we keep discussing all these in the rounds as well in the tumor boards. There's been a very good approval from them as well, really no complaints coming in. And so I must say that this has been a success for us.
So you talk about your wait times going down in the paper, which makes sense because you've got people dedicated to doing these, and your adequacy rates went up. And I think the wait time finding, as I said, makes a lot of sense. Why do you think your adequacy rates went up with these mid-level care providers?
So I think it's a consistency. It's the same people who have been doing it. We have the 4 sonographers who are trained to do this, and they kind of rotate 1 in 4 weeks. So for 1 full week, they would do the thyroid biopsies. And for 3 weeks, they'll be doing ultrasounds in the ultrasound department, come back to do biopsies again. And, they cover for their vacations as well. Sometimes they'll be there a little bit more than a week in a month. And I think that consistency is what has led to this benefit. So I must say, it's very similar to, sonographers now do the ultrasounds, and they're very good at it, having done it over the years. Initially, we would have, some days it's a first-year resident who might be in the rotation There might be a fellow with some are trained better than the others. So I think that's the predominant reason, the consistency. They take pride as well that they're doing this, and they're doing it very well. I truly believe that this really has been one of the biggest benefits of having them in this program.
Now, when you get informed consent from the patients and when these sonographers get the informed consent, are the patients told that it's a non-physician who's going to be doing their biopsy?
Yes, absolutely. In fact, the sonographers have been, they are able to take the informed consent, and they will do it in our name, the staff who's there, and in their names as well. So most of the patients are absolutely fine. They said that, they're told that I'm a biopsy specialist, a thyroid biopsy specialist, and I work with so-and-so. Dr. Guy is with me today, he's in the other room. And some patients, yes, they do ask. I would have thought this was going to be done by a physician, and they ask for it. And frankly speaking, if now I'm asked to come into the room at the time of the consent, I actually tell them, I've done 5 thyroid biopsies in the last year. The person here has done over 1,000. You really want me to do your thyroid FNA? And most of the time, in fact, always, they've said, no, I'm fine with it. I just wanted to make sure that. And then we have to convince them that this is a program which has been approved by the hospital. There's been a training program, and there's an evaluation which happens every year as well. There's a fixed number that they have to do to maintain the competency. So, and I think they're all, it's just that, you need to go in and speak to them for a minute, and everything is fine after that. Yeah.
And given your success with this program, with your mid-level care providers, are you using this in other areas, either in ultrasound or elsewhere in your imaging department?
So in the past, the idea came because we've been using the help for PICC lines, as in many hospitals. They provide some fluoroscopy assistance for things like hysterosalpingograms and speech swallows in the past. It just frees up the radiologist. So there's been a precedence in the past. Have we increased it since our thyroids, the scope of their practice? We really haven't as yet, but we're talking of things like, could we add paracentesis? Sometimes it just occupies the room for a long period of time. Is that something, chronic patients, liver patients, where you're draining 4 liters, 5 liters, is that something they can do? It's just that we'll have to go through the whole process because, again, you go back to the CMPA, the CPSO. We haven't started it, but yes, we've been talking about some simple procedures such as that.
And you mentioned early on that you got the radiologist acceptance very easily. Pathology took just a little bit of work. What about your referring clinicians? Were there any issues with them?
Really, surprisingly, there really wasn't. All the endocrinologists were on board. And we kind of cater to, we're a group of the university hospitals. It's not just the one hospital. So we have the Toronto General, we have Mount Sinai, and the Women's College Hospital, where we have the endocrinologists, apart from Princess Margaret Hospital here. And all across the board, no, we have not had. In fact, once or twice, I've had a positive feedback from the clinicians saying that they were very happy with it. So yeah, surprisingly, nothing really from the endocrinologist. Everything has been well on that.
Wonderful. And what are your wait times now for these thyroid biopsies?
Oh, it's less than 3 weeks, I would say. It's
okay.
Less than 3 weeks. To the extent that we are thinking we might even start doing them 4 days in a week instead of providing the service 5 days if the wait times keeps coming down. So yeah, so it's been less than 3 weeks. I think today it might be about 3 weeks.
Wonderful. Well, thank you so much for your time and this discussion. I really appreciate it. Of course, we're talking about your study in Canada. Do you have any ideas how this might work in the United States? Do you know if we could do
I don't know. I would think it's a little different in the U.S. And having not worked in the U.S., I don't want to be commenting too much. I believe a lot of physicians rather than radiologists also do these procedures in the U.S. in their clinics. And I don't know if they would be willing to have their assistants do this or not. But I think here it's in our experience in our hospital, it's really been very good.
Okay. Well, again, thank you so much. I really appreciate your time.
Thank you for having me. It's been a pleasure.
Hello, my name is David Kalmus. I am Deputy Editor for Neuroradiology. I'm joined today on this podcast by Professor Qijian Chen of the Department of Radiology at Taipei Medical University. Dr. Chen, welcome to the podcast.
Thank you. Good
We're here
evening.
today to talk about your publication entitled Gender Difference in Mild Traumatic Brain Injury, Functional MRI Study. Congratulations on your paper.
Thank you.
So can you briefly tell us at the beginning what you did in this experiment and your major findings?
Okay. Actually, in our clinical practice, we found more female patients seek to medical attention after mild traumatic brain injury. However, according our past experience that in the epidemiology study, we found actually male NTBI patient outnumbered female. So we wonder there may be some sex factor difference in the NTBI outcome. And when we review the literature, we found the result is actually mixed. Experimental studies show that female animal actually have better outcome than male. However, in a human study, male actually had a better outcome than female. So so we try to understand that. So therefore, we conduct a study. We study 30 patients with NTBI and 30 normal control. And both groups contain equal number of the men and the women. And patients under functional NI within 1 month after injury, and a follow-up functional NI study at the 6th week after the first scan. And all the patients also underwent neuropsychological tests, including digital span and continued performance test. And the initial result shows that NTBI patients show increased activation in working memory circuit in men, but the decreased activation in women compared to the control. And at the follow-up, men with the NTBI returned to a normal activation pattern similar to the control, whereas the women show persistent hypoactivation, suggesting ongoing working memory problem. And also the neuropsychological result shows that among the women and the total digital span score were lower in the NTBI group compared to the control group. So this finding provide evidence that female gender may be a risk factor for working memory impairment after NTBI.
So it seems somewhat surprising that there are differences both at baseline and at follow-up, that the activation is opposite in men and women at baseline. Was this an unexpected finding?
Pardon?
Was this finding of different activation, of hyperactivation in men and hypoactivation in women at baseline or early after injury, was this finding a surprise to you?
It's not surprised me. It's only because it's compatible with our clinical finding. Because actually, more women seek for medical attention after NTBI. So it means usually may think it's because women are more like to admit they have a symptom, but actually it's not. Actually they have real problem than men after NTBI.
And is there any obvious explanation for this? Is it?
Yeah. Till now we still don't know why, but there are some assumption. One possible explanation is maybe biomechanical, that women may have because their head are smaller and because their neck muscle are weaker than men. So when it comes to NTBI, their ability to absorbing shock of the impact is weaker. This is one explanation. And the other explanation is that maybe men and women use different brain region in working memory task. And the brain region women use during working memory may be more susceptible to injury. But this only hypothesis is need to be tested in the future.
And can fMRI be used for prognosis based on your findings? That is to say, can you predict what will happen to an MTBI patient early after injury based on patterns of activation?
Yeah, I believe it seems that NI is very sensitive to the NTBI injury. But unfortunately, at present, we are only do a group study. We cannot apply it to the individual level. So maybe more work need to be done in the future to extend the usage of the functional NI to the individual level.
And in a related note, can you predict or can you envision that any type of specific therapy, either medication or other cognitive type therapy, might be individualized to men or women based on your findings?
Unfortunately, at present, the treatment for men and women after NTBI are the same because actually it's no pharmacological or other rehabilitation treatment can be benefit from this. And actually 85% of patients will recover spontaneously within 3 months. Only 15% have persistent symptoms. This group of patients we need to pay more attention. But actually we don't know which one should be pay more attention in the beginning. But right now we know maybe female we need to put more attention. And maybe I know have some drug they are in the clinical trial, but still not have a very obvious result at right now.
And could it be that the mechanism of injury was different between the men in your study and the women in your study that might have affected the outcome, or were the mechanisms of injury similar between groups?
They both have the same, no difference between the mechanism of injury. Most of them suffer from the motor vehicle injury, and a few is a sport injury, and maybe less in assaulted. Yeah. So the mechanism seems no different between men and women in our study.
And can you share with us studies that are ongoing at your center or studies that you would like to do in the future to elucidate the mechanism or offer prognostic indicators?
Okay. Actually, the result only preliminary. Question remain, including just I mentioned, the pathophysiologic basis of working memory and the role of the sex hormone and at the time and the follow-up injury. So we plan to combine functional NI and the variable neuropsychology test and the direct measurement of the hormone level, both at the injury time and the follow-up stage. And we also try to combine other imaging modality such as diffusion tensor imaging for the structural integrity, and resting state functional NI for the functional connectivity, susceptible weighted imaging for microtrauma, and perfusion study for the hemodynamic evaluation. also the NR spectroscope for the metabolite. We hope using this modality can further help us to explore the underlying pathophysiology and cause of the sex difference in the NTBI.
It sounds like a very comprehensive study. Is that ongoing now, or are you planning it in the future?
Actually, we have finished a little about the SWI, susceptible weighted image for the microtrauma.
Sure.
But we didn't find the difference. The number of microtrauma, a microbleed between these two groups, it actually is the same. So nowadays we try to use functional connectivity to differentiate, to detect any difference between these two groups.
Sure.
Yeah.
Okay. Well, I want to thank you sincerely for supporting our journal. The study, a prospective study of MTBI, is a welcome study, and it was very well done. And we look forward to receiving future papers from your excellent group. Thank you, Dr. Chen.
Okay, thank you. I hope we our future our work can submit to radiology very soon.
We look forward to it. All right.
Okay, thank you.